right. Thanks for having me today. It's been a while since I've been on the campus up here. In fact, there's about 10 or 12 new buildings since I've been here. So even though I was born and raised just south of here in a little community called Rigby, so you drive past it and you thank them for inventing the TV and drive on up to Rexburg. So, but we always, that's our claim to fame. And I was in my grad school in Ogden, Utah. We had a professor that tried to claim that it really wasn't invented in Utah, or not in Rigby. He said because the guy's family was from Utah, so tried to argue that, but I wouldn't let him. It was interesting because I didn't really realize growing up that the TV was invented in Rigby, and I was on my mission in Venezuela, and I was some newspaper was sitting on there at the bus stop, and so we pick it up and read an article on Philo T. Farnsworth from Rigby, Idaho, about the inventor of TV. So I thought, yeah. So things that you don't know about when you grow up and you're in the town, and you don't even realize that town's famous. So that kind of leads into a little bit about me. I graduated from Ricks College. I was in 1999, so went a year of college and then went on a mission, and then graduated from Ricks after I got back on my mission. The 24 or 28 credits of Spanish really helps you get your associate's degree quickly. So otherwise, I was on the 3-year track. But then I transferred down to Weber State University, and saw a little bit of my bio there. I'm kind of a cowboy, so I was on a rodeo scholarship all the way through Ricks, and then that's how I ended up down at Weber State in Ogden. So went through a whole bunch, and probably you guys are going through the same thing. What am I going to do in my life? What is my career goals? When am I going to get a job? Am I ever going to get married? Those types of things. But don't worry, it all comes. It all comes. But I ended up I really like business, so I really like the business aspects. I got my undergraduate in business management. There was a lady in my ward in Ogden, how all these weird things happen. And she was the chief nursing officer at a big hospital there in Ogden. And she said, you really ought to go into healthcare administration. I said, what's that? And so she kind of talked to me a little about it. I was introduced to a CEO of a hospital down there, and kind of sat down and talked to him, and figured out, asked him what he did, what does it mean to run a hospital. And it actually was really good. He gave me some really good advice and some opportunities to move forward in the industry. I got a job there, just working in materials management and delivering all the supplies and inventories throughout the whole hospital. And that was actually a really good opportunity to kind of learn, that part of it. There's a big side of the hospital business that's all in materials and inventory and management, and so that was pretty interesting. And then I worked a lot with the operating room because that's where most of the supplies went, and they recruited me up there to work as an anesthesia tech, and so which was a good opportunity to get into the hospital, not just on the business side or the material side or the management side, but actually get into the patient care side. And that's really, if any of you have had a chance to work in the patient care side, you understand. If you haven't, I encourage you to try to get a little bit of experience in that, because that really truly defines what a hospital is there for, what healthcare as a whole really is. And it's really taking care of a patient, really finding out what their needs are, helping them get better. It's just the most rewarding thing to see someone come in with multiple injuries or multiple illnesses or whatever it might be, and to have them leave happy and healthy and to be able to get on with their life. And I don't know if anyone's ever been really sick for a long time, but it's very debilitating. And and if it's something that you really enjoy is to serve people, to serve their needs, and to help them feel better, this is a great field to be in. And that's why ultimately I chose that. I thought this is really what I like. I like the patient care side. I usually passed out beside of blood. So my first experience in the operating room was my buddy that was supposed to be my buddy that recruited me to come up there and work with him. Walked into an operating room where they're doing a craniotomy. Does anyone know what a craniotomy is? So they take the skull off the head and they start digging into the brain. He walks me around to the curve, to all the drapes, and they said, if you can look over into this and not pass out, you're going to make it. And prior to that, I had zero clinical experience. I passed out every time I got my blood taken. I was both here and also on my mission a couple times where I had to get a shot and went out. So, but couldn't figure out what am I doing? What am I going up in the operating room for? But you wonder where kind of how your career. My wife and I have talked about this. In fact, sorry, I forgot to introduce my wife back there. Riley's kind of hanging out with her, but my wife Megan. In the bio, it kind of sounds like I met her right after I got my mission. We were married within 3 months. It really wasn't that quick. So we dated on and off through high school for about 4 or 5 years before we both went on missions. And came back and got married. So even though we were at Erickson when we got married, it was we knew each other for a while. But not that there's anything wrong with the 3-month engagement. That's okay. But now I got to remember what it was. Oh, so the operating room. And I couldn't figure out why I wanted to go there. Now looking back at all the things I've done to try to build my career in healthcare, I look back at that about 2.5 years I had the opportunity to work in there. That was probably the most rewarding and most, I think the most opportunity I had to learn the most about healthcare was actually in the operating room. And got to work with a lot of physicians. You work side by side with physicians. You learn kind of how they think, how they do things, and the importance of when they say they need something, it's I'd say 8 times out of 10 true. but especially in that situation, it's really important to build a relationship with the physicians, and that helped me in my career moving forward. And because that is one thing that you'll work with no matter what type of healthcare arena you decide to go into. Building a relationship with physicians and understanding them and understanding their needs is very, very key. That kind of leads into the oh yeah, go ahead.
What exactly were your responsibilities, and what did you do when you were in the anesthesia tech?
So when I was an anesthesia tech, I worked with a group of anesthesiologists. There were 7 of them, and then a group of CRNAs, so nurse anesthetists, and they had a contract for all the hospital, for all the sedation or any anesthetic needs to happen in the entire hospital. So it'd be in the operating room and the labor and delivery departments and the endoscopy suites, wherever they needed that. So they had a schedule throughout the day. Typically what I did was I'd go in and you had to make sure all the rooms were prepped for the day. So you had all the medications ready, all the syringes, all the supplies that they need on a daily basis, all the intubation materials all prepped and ready to go. And you had a schedule of all the ORs. We had 8 ORs, and so I just had to make rounds throughout the day in between every OR and make sure that the providers had what they needed. I'd help start IVs. I prepped the medications that they're allowed to prep. Not the narcotics, but some of the basic saline stuff. We'd get all ready for the syringes and ready for the providers. We'd help with them, bring them back to the room, get them set up on the operating room table, and then get them to sleep. And so it was, and then a lot of the other things as far as getting supplies ordered, making sure that everything was stocked, and all that kind of stuff. So a lot of the grunt work, which I really did enjoy. It was, I grew up on a farm and ranch, so I was just happy to, in the wintertime, be able to work inside, go outside, and battle the cold. And it seems like people do respond better than cattle do. So I tend to listen a little bit better, but not much, but a little bit. So anyway, so thanks, Riley. But yeah, that's and so if you had an opportunity to get any type of experience like that while I did that while I was getting my master's degree. So I was working full time there at the hospital. I was a full-time student to get my master's degree, and at the time I met with the CEO. He had mentioned, he gave me advice to probably just go get your MBA with an emphasis in healthcare administration, and so that's what I did. It's the only guy I knew that was in the industry, so I did what he said, and he was pretty successful. And the reason why he told me that is because if you get into it and maybe it's not for you, maybe you get into the first few years of your career as in the healthcare administration, and this is really what I want. But if you have your MBA, that can kind of gear you towards other industries as well. Whereas if you focus just on a MHA, then you're pretty much set to go into healthcare healthcare administration. And it worked out for me. I enjoyed it. Other people, they really like going to the MHA program because they set you up in some internships and in your first job, kind of get you in the door. So that's also depending on where you're at in your career at that point. So a little bit of advice that he gave me to pass on to you guys. So it gets into my presentation today, and one of the main things I talked earlier about is relationships with physicians. How do hospitals, clinics, or whatever other type of healthcare organization, how do they make money? Physicians, or mid-level providers, nurse practitioners, physician assistants. You know, we have to have everybody as far as the support team, but me, myself, I can't order a single lab test, I can't order an x-ray, I can't do a surgery, I can't admit a patient to the hospital, all the things that drive revenue in the healthcare field. So if you have no physicians, no providers, then you probably won't be open. And it's interesting because I chose to come back and work in a more of a rural setting. Oh, there you go.
Could you just explain how successful BYU has been with recruiting
Yeah.
physicians?
And that's part of the presentation, so just, sit on the edge of your seat, it's coming.
I'm waiting.
And people say, well, how do you get a physician to come to a little small community, to a small hospital? These physicians they've been to school, they've been in these big cities, they're smart, they don't want to come to a little tiny town. I don't know if maybe you know, but Blackfoot, where Bingham Memorial is located, it's a little town with 10,000 people. There's a pretty big dry area around us, but it's still a little small community. So I guess just to kind of get a feel for you guys and where you come from, how many are from considered small rural communities? Pretty good number of you. So what's your guys', if anyone wants to share, what's your guys' hospital like in your hometown? You know much about it? Yeah.
I'm from Colorado.
Okay.
Shoshone County Hospital is the one up there. And in our town, it has a really bad reputation, actually. People travel from Coeur d'Alene to go to Cooney instead.
Yeah. Anybody else?
Cornerstone, I know.
Mm-hmm.
Our hospital, most people travel to San Antonio or Fort Wayne also.
Okay. So a lot about migration out of your community to go to take care of the healthcare needs. All right. That's not atypical in small towns. And being Memorial Hospital about 12 years ago, had the exact same reputation. Everybody from Blackfoot decided, well, it's only 20 minutes to Tidal Falls or Pocatello, so no big deal, we'll just drive for all their health care. The hospital was a little tiny hospital, kind of run down, and they delivered a few babies, had a few tonsils taken out in the ORs, and every once in a while they get a patient admitted to the hospital and be on the floor. But that's where it was, just to show you about 12 years ago. The difference that it made is one, the board of directors decided, that's the board of directors in your facility can really lead how the hospital goes, what direction they want to go, and where they want to become. The board said, we're from Blackfoot, we're from this area, we deserve a hospital. Why do we have to settle for such a, basically a nothing hospital? We have we make good money. We like to support a hospital, and so they went out and searched for a CEO that had that same vision, that could actually bring a hospital from basically it was about $12 million a year hospital, $12 million a year in gross revenues is what the hospital was 12 years ago, and they wanted to turn that around. It would have to be a real hospital. And so they brought in a CEO who came from California that had a reputation for turning around small hospitals. His first job was up in Republic, Washington. So a little tiny town up by the Canadian border, where you guys are from. And had he started there when he was really young, and he kind of had that reputation of going and staying about 5 or 6 years in each hospital and kind of turning it around and getting it profitable again. But he came here and he said this was the worst hospital he's ever seen. So he's been in some really crappy hospitals, and this is the worst he'd ever seen. But he said that there was some hope. And he said he walked around the hospital when he was interviewing. He talked to the nurses, he talked to the techs, he talked to the people that worked there. He said there was light in their eyes. There was still a sparkle. they really enjoy taking care of patients. They love their patients. And he said, that's what made me decide I want to stay here, because I think I can do something with this. And he did that. He came, and I started there about 8 years ago. And from about 12 years ago, we went from a $12 million a year hospital to this year we're just over $200 million. And so it's been a huge increase. We tell people, especially with the physicians that we try to recruit, it's like, it's not that everybody in Blackfoot also got sick. You know, the INL didn't have a leak, and we don't have everybody didn't get any nuclear poisoning or whatever you want to call it. But it's because we decided to actually form a real hospital. And we brought in physicians, brought in specialists, and we out-migrated. We actually brought people that were leaving Blackfoot and kept them home, and they didn't have to leave anymore. So that's what it is, and I just wanted to kind of give that example that it really is possible to have a great career in a small community. You can make a huge difference in a small community hospital if you have the drive and the willingness to do that. Sometimes it does take the board support. I had a couple of my departments that I manage are different contracts we have, management contracts we have with other facilities. And we had a great experience up in the hospital in Driggs, Idaho. They were at the same point that the Blackfoot Hospital was about 12 years ago. They were ready to close their doors. And they couldn't make payroll, they couldn't, they were basically ready to close their doors. We went up there and kind of found some different things we could do. They hired us to be a management, to manage the hospital for a couple of years. And we turned that facility around to where they're very, they're quite profitable now, and they did really well. And little things that you can make just after knowing what a small hospital needs. And that's kind of what we'll go through these slides, is that you have to really kind of find out what you want. I had another experience at another hospital, small hospital. Can you just click the button?
There's a trigger.
There we go. And another small hospital, funny story is that we had a hospital in Arco. So speaking of the Idaho National Lab, there's a little tiny hospital out in Arco, Idaho. And same type of thing. We walked in the first day, and instead of fixing the windows, they just put some cardboard up on some of the windows and with some duct tape. And I was like, wow, this is, at least the hospital in Driggs was actually a very well kept facility. Just didn't have any patients in it. But this was, there was the plant maintenance was all for. But we, same thing, went in, tried to, figure out a few things to help them generate some extra revenue. And we got to the point where it was a battle with the actual board of directors. The board of directors kind of just were happy with what they had. They knew that the hospital struggled, but it was a taxable entity, so it was never going to close because taxpayers just get paid for it. And so there wasn't as much of a drive to make a big change there. The funniest story though about that facility is we're in there one of the days and we're meeting with a couple of the managers, and all of a sudden we're in this office, and down the hallway I hear this, and I swear I wake up, that just someone's phone, someone's ringtone or something like that. It had to be a little later, and I get up and I'm like, there's no way. I walk out, and their family practice doc, a little older lady, was walking her pet goat through the facility, coming to make rounds. And I thought, where in the heck am I? What just happened? Literally with a leash and a goat walking through the hallway of the hospital. So that, you can kind of imagine that was kind of the state that it was in, and no one wanted to have any changes. It was just pretty much, leave us alone and we'll be fine. So it's there are situations where it is a little more difficult to make changes in a small community if they're not willing to make those changes. The positive thing is that we were at Blackfoot, they were very willing to make the changes. When we look at how do we become successful as healthcare administrators, put a few keys here. Number one has to start with quality. No matter what you do, no matter where you're at, if you start with quality healthcare, everything else is going to fall in line. Our board, I think it's in a different slide here, but I'll tell you anyway. Our board of directors has a motto, and it's basically quality drives volume, volume drives profit. If you try to start it any other way, you're not going to be successful. And so if you start with good quality care, everything else falls into place. Your reputation gets out there that you will get better if you go there. If you go to this position, you're going to get you're gonna get great service and you're gonna get better. And that's how I had to start. And that's how it started being, we started offering, getting quality care services. We might only do one service. Maybe could do lab work, but we did lab work really, really good. We brought in a really good radiologist. Our radiology was really, really good. And then it just led to more and more. So quality care, anywhere you go, especially in small communities, the biggest and the most important thing is to have a solid primary care provider base. Nothing happens without primary care physicians. And in the next several years, there's gonna be a big shortage for primary care physicians, so we have to get kind of creative of how we do that. And one way is to really focus in on some of the mid-level providers, nurse practitioners, physician assistants, because if you don't have that entry level to where you get patients into the door with a primary care physician, you're not gonna have the success with the specialists who end up doing the surgeries in the operating room, and doing spine surgery, doing orthopedic surgery. Without that primary care base, you won't be able to have that. And that leads to basically the profitable areas of the hospital. You're not gonna make any money doing primary care. You just have to know that. A lot of it Medicare, Medicaid, you don't get paid very good for that. And so you have to basically subsidize your primary care markets with specialists. And specialists have to be busy in order to do that. So there's a big base of primary care providers. Then you start bringing in specialty services and surgical services, and then ancillary services, which are all your outpatient stuff, your physical therapy, your lab, x-ray, those types of things. So that's how you kind of start building the base, especially if you're coming into a small community where there's none of that. You don't have a very good base of primary care providers. Start recruiting those before you start trying to bring in an orthopedic surgeon, or you start bringing in a general surgeon that actually makes money in the OR, but if you have nobody to refer to them, then it really is very difficult. All right. So when you start going through recruitment, and we do a lot of recruitment in our organization, we have clinics in Pocatello, we have clinics in Idaho Falls, we have clinics in Shelley, several clinics in Blackfoot, and then obviously the main hospital in Blackfoot, along with the second spine specialty hospital that we have with a bunch of neurosurgeons. And so what you have to do is try to figure out, talk to yourself, okay, I'm just starting this, I'm in this new community. What does our community need for healthcare? What types of physicians would actually benefit our community? You really got to get to know that. You try to start bringing in a whole bunch of docs and say, that's how you make money. You got to have physicians. That's how we keep this hospital going. But if it's not a real big need in that community, then those physicians will not be successful, and it'll cost a lot of money that you won't get back. What type of specialty and training make a difference? How would your community benefit from a doctor trained at an elite medical school? One of our, if I think kind of the things have changed, it used to be that patients really went to physicians for just whether their name or just who they worked for, or if they're a member of the same church or whatever. Just that way they have they're their neighbors who live in their community. We kind of did some study before we started our last real big round of recruitment, and found out that actually consumers, they have the physicians who may have been trained at Harvard, or trained at Mayo Clinic, or trained at Cleveland Clinic, or some of these big name facilities. That automatically rings, wow, they must be really, really good doctors if they came from Mayo Clinic. Mayo Clinic has this big, huge reputation across the country. So we decided we're going to focus our efforts. Obviously, you have to find a physician that fits in the community and that actually understands the culture. But we started looking for some physicians who were trained at these big facilities, and to help us get to the next level as far as the quality that we wanted to offer. And so that's where that is. And then being able to recruit doctors in the community to meet the needs. One thing you do is that's called a community needs assessment. And so it's something that you can do. I think we had Idaho State University do one for a couple of small communities that we were helping manage, and they came out and just do this big survey and put the community needs assessment all together, and we got a grant for it. So it's things you can easily get accomplished. But it really does tell you a little bit about your community, what they expect as far as healthcare, what they expect as far as their physicians, and what services you think will be successful in that community. Kind of talks about what's leaving your community. You guys spoke of everybody just goes out of town for their services. And it's unfortunate, but it happens. So if you can find out, what are they going out of town for? Is it primary care? You think we can maybe just build good primary care here, and people will stay for that? Is it their radiology services, or they legally go get an MRI or a CT or something like that? Or are they actually just saying, I have no confidence in this place, and it doesn't matter what you do to bring something in? But you have to kind of start. What's the easiest one to tackle? And typically primary care is, people really don't like to travel 20, 30 miles to go get their runny nose checked, or to see about an infection or something like that. That would be nice to have it right there, close and convenient. So that's, got to find out what your community needs, especially in a small community. And you kind of want to figure out who are you guys, who are you as an organization? Find that out. What do you want to become? What direction do you want to go? And kind of map out a plan. This works. I mean, we're talking about small community hospitals because that's where I have the most experience. This can be pretty true for any type of organization you're in. We had a strategic planning meeting with our board of directors about 3 years ago, and one of the board of directors said, "Well, the Mayo Clinic was started just in a little cornfield in the middle of Minnesota. That's how it got started, and which is true." So they said, "Why can't we become the Mayo Clinic of Southeast Idaho? Start that in a potato patch." So why not? And that's the kind of direction and leadership we had on our board, is that more of the why not instead of the we can't do that. And it's been great to work with a board that has that type of energy and foresight. So you can start something amazing too. I talked to you about the people in Blackfoot kept on saying, well, it's only 20 minutes to go to Pocatello, it's only 20 minutes to go to Idaho Falls. We wanted to change that, and now people from Idaho Falls and Pocatello say, well, it's only 20 minutes to Blackfoot. So we went through the numbers today, 25% of our total volume come from Pocatello. And so they are now leaving their community, which has this big, nice, brand new hospital, and they're going because they're looking for quality care. They're leaving because they've had a good experience with one of our physicians, and they're coming now to Blackfoot. We put these satellite clinics in so they can take care of the primary care in their own hometown. But when it comes to a specialist, we can bring them to Blackfoot to have their surgeries done, to have their MRIs done, to have the outpatient services completed, and that's what really drives revenue in the hospital. Right?
You might be planning on talking about this later, but how do you get this out when you're making these changes in the hospital to improve certain areas? How do you get that out so the community knows about it, or is it just time? And
it is. You've probably seen a lot of our marketing. We do a ton of marketing.
Super Bowl.
And we're on the Super Bowl. But you have to kind of jump out and say, if I want to be recognized, how is the best way to get noticed? And you have to do marketing. We have our physicians do free seminars for the community to come and listen to something, whether it's something about diabetes education, whether it's about about your arthritis in your knee. Our physicians will take a night out of their week and do a seminar for the community. That gets out. The number one thing that we all know in marketing, what's the number one thing that gets the word out?
Word of mouth.
Word of mouth. So that's why you have to start, like we talked about earlier, with quality services. If you bring in a guy, we got this great orthopedic surgeon, he's just horses to the patients in the exam room, that doesn't matter. You can market all you want, and no one's going to go to them. And so you really have to start with that quality and bring in the types of providers who share the same desire to provide quality care, be helpful to the patients, and really take care of them.
We'll probably get more into this, but has it been difficult competing against the NERMAC that's been established for a long time? It's very profitable. Doug Crabtree's been there a long time, and they've been successful. Has that been a challenge going against NERMAC?
It's not so much been a challenge as it is an opportunity, and that's where we've looked at both in Pocatello and Idaho Falls. That's why we expanded so much there. It's funny because in our own hometown in Blackfoot, we only have about 59% of the market share, because there's still those people in their head that still remember the hospital 15 years ago that said, nope, I don't want to go to the hospital, I got to go to Idaho Falls or Pocatello. Doesn't matter what you do, they're not gonna change. So, you know, that's why you go, and then you go to Pocatello, where you think, man, they have a really nice hospital. They're brand new and a lot of nice services. It's a tertiary care center. But there's people in that community that says, I just wish we had a choice. You know, because I don't like that hospital. And so you look for those types of opportunities. And Idaho Falls is the same way. In Idaho Falls, or MAC, they have reputations for different things. And so you kind of work on the things that people don't like about RMAC, and you try to go and offer that service to make it better. So we see it more as an opportunity, not so much as a challenge. And we've had good success. We have about 8 or 9 specialists that are in Idaho Falls pretty much every day, and they bring a lot of patients back to Blackfoot. Doug doesn't like us for that. Nor does the facility in Pocatello, but it's a competitive market. It's a business. Doesn't matter what we're taking care of patients, and it's great. It's fulfilling that way. But in our roles as administrators, we have to understand that it still is a business. We have to make sure that we go out and compete. We can't just say, oh, well, they got mad because we started seeing some patients there, so let's just pull our physicians back and not rock the boat. And you're going to have to rock the boat a little bit, and especially some of your small communities, you're going to have to do that. Those big hospitals that get all those referrals from small communities, they're happy because they get all that revenue. When you start bringing that back and taking it away from them, they notice pretty quick. Talk about that increase of about $186 million over the last 10 years. That's been taken out of somebody's pocket, north and south of us. Yeah, it's competitive, but you offer a good service and allow the patient to choose, just like in any other business. And you provide the service, and they'll choose. Another good way to find out what you need as far as in your community, we started out with what we call a visiting specialist clinic. So we started hiring some primary care docs when we first about 10 years ago, and started building that base of primary care. And then we started talking to the specialists in Idaho Falls and Pocatello and saying, hey, we have a lot of primary care docs. We'd like to keep our patients in our own community. And would you guys be willing to come and actually do a clinic in our facility? We'll set it all up for you. You just have to show up. We'll have all the patients ready for you. All you do is just chart it. We'll pay you, and you don't have to worry about any of that stuff. And so we got an ear, nose, and throat physician out of Pocatello to start with us very first. And he came up and started seeing, the young kids for tonsils and adenoids and things like that. And that was really good because the family said, that's one less trip I have to take to Pocatello. And they can see him right here. He started ordering a lot of labs, ordering x-rays. He can get all of his surgeries on those patients in our facility. So all of a sudden, the revenue cycle started generating. And just by having one specialist, just give us a chance. He'd come once a week for half a day and see 10, 12 patients, and then he'd go to the OR and do about 4 or 5 surgeries, and all of a sudden it's like, oh, now we're actually, we're having we're making some money now. This is great. So we started doing that and adding more and more specialists. And this specialist, we cater to him like crazy. He delivers lunch on a silver platter. Everything he needed. He was right there. We had 2 nurses just catering to him. So we wanted it to be a very good experience for him, and then for him to go and tell his buddies, hey, you guys ought to do this too. It works really well. And so that's how we found out. Okay, what specialists can we actually have here? We went with orthopedics for a little while doing that same thing. We found out, man, we can sustain a full-time orthopedic surgeon. And so we go out and get a couple of orthopedic surgeons. Same with general surgery. We had some surgeons come in and just do some rotations, and we found out we could actually keep the surgeon busy. Up to the point now we have a lot. But that's another way to start, especially in a small community where you're wondering, instead of trying, how do I keep my patients here? Bring a physician in that will just see the patients there. The only thing you have to be careful with is that they come and see him and then say, hey, by the way, next week come to my office in the other town, and we'll take care of everything else there. But that happens sometimes. You just kind of watch it, and maybe that's not your partner. But a true partner will come in and help you build your programs. So starting with that, we actually last year as far as just 2013, we brought in 14 new physicians, all different specialties, as you can see, all the way from family practice to pulmonology, to interventional radiology, to orthopedics and sports medicine. We started a new sports medicine program. It's called the Orthopedic Institute, and we have contracts about the high school sports all through the region, and and then also some of the ISU, the intramural club sports, that kind of thing. So it was a good opportunity to kind of build a new program throughout the region. It's been very, very successful. Fran?
I know you hired 14 last year, but how many do you have total?
We have 45 employee positions. And so as of 10 years ago, we hired our first family practice physician. We had one. So we've definitely grown quite a bit. We've taken advantage of some opportunities we've had with partners in both Idaho Falls and Pocatello, and establishing really good relationships with physicians. We own part of a surgery center in Pocatello. We have a second hospital I talked about earlier, the Idaho Doctors Hospital, which is a spine hospital. And that is something that's really going to be more prevalent in the future too. Is just always remember the word joint venture. Joint venture is going to be the wave of healthcare in the future with physicians. Physicians' reimbursements continue to get cut. Every time they turn around, they say, okay, that service isn't covered anymore, or it used to be something you could bill 3 different codes for. Now you get one, and you get the same price for that one code. More and more, you're going to see physicians just complain about getting their reimbursements. So what do? Instead of just saying, well, that's too bad. The hospital's doing okay. So just buck up. It's about time to come after you instead of the hospital. Instead of doing that, we look for opportunities to joint venture or do a partnership with physicians. Allow them at some point to be able to take care, get some of the technical component of a reimbursement instead of just a professional fee. And then they have some ownership in it. The way that's very successful story with the Idaho Doctors Hospital is they're 4 neurosurgeons. And again, 4 neurosurgeons in a little tiny town of Blackfoot. Are you kidding me? And every time we talk to a physician, every time I call a physician for the first time and say, just want to tell you about our facility, we're looking for doctors like you, and let me tell you about what we do. And they sit there and say, no, where are you at again? Blackfoot, Idaho. How big is the city? 10,000. How big is the hospital? We got 25 beds. And they just can't believe it. Cannot believe it. And so we bring them out, and they have to see it to believe it. But that hospital is a prime example of a good opportunity to partner with physicians. Now, were those 4 neurosurgeons, would they be there if it wasn't for this joint venture? I don't know. But we decided it's better to split with the physicians and allow them to take 40% of the profits and us take 60. That's better than 100% of nothing. So if they weren't there, then we wouldn't have that program. So look for opportunities to build relationships and partnerships with physicians. It's kind of, some physicians think that's taboo. They're always taught, don't ever agree to the hospital. They're always trying to slide one underneath you. So don't ever work with the hospital. Don't ever partner with them. They're lying to you. They just want you so they can make money. And so you have to bust through that and actually establish some good partnerships.
All those physicians at the Idaho Doctors Hospital also work at ERMAC.
They take neurosurgery call. One of them does.
Oh.
Or actually two of the 4 do.
Yeah.
But so it doesn't. And so you can work with your competitors. The docs who started bringing in the visiting specialists, they worked for other entities. They worked for other groups. They worked for Fort Bluff and Mountain View and different places. But they want something different in their career as well, in their lives. And so to be able to break it up during the week and say, this week I get to Black for my one day. It's really fun. They treat me good, and I don't have to worry about all my crazy stuff at the office, and I can just go see patients. So look for those opportunities. So a little bit about recruitment, how we were able to have success. You have to have a good recruitment team. So in-house, you have to have a good recruitment team that really looks for physicians, takes care of them while they're here visiting, knows the right questions to ask on the phone interviews, and really find good quality candidates. Screening. There's a difference. There's two different kind of firms out there that will help you with recruitment. One's called a contingency firm, and the other one's called a retained firm. We've had more success with the contingency firms because contingency means that if they don't sign the doc for you, then they don't get paid. A retained firm, sometimes you can be a very specialized physician, then they're good to use because they dig right into those specialized searches, and you have to pay them all the way though as you go along, and whether they get somebody for you or not, you still pay them. So we typically use mainly contingency firms. A lot of online databases now. We get a lot of The last of those 14 positions that we hired, only 2 of those came from a search firm. Everyone else we either found on our own, going through like medical schools or residency programs, or just online advertising for it, and doing our own advertising online with the doctor journals, and subscribing to a couple of databases actually where physicians go on. It's kind of like the LDSsingles.com. You go on as a physician, you say, this is the type of opportunity I'm looking for. I'm looking for a small community. I'm looking to be in the state of Idaho, Utah, Wyoming, wherever. And so we subscribe to that. So anytime a physician signs up and says they want to look in Idaho, it shows up in my email box. It says this is the type of physician, and just contact information and call. So that's kind of a good way to do it as well. Because then you really find that people are looking to be in your area as well. Those are keys to retaining good physicians, is making sure they like to be here. We've had a couple of physicians that moved here, started, and then their wife decided they didn't like Idaho. And it was miserable for the physician because the wife said, I'm going back to Kansas for her. She was mad. And that physician was miserable for a year because he didn't have a wife there. And, the wife obviously took the kids too, so whenever you decide you're done with Idaho, you come back and live with us. So. But so that makes it difficult. So you really want to screen those candidates, screen those docs, and say, I really want to be in that area. I enjoy the outdoor activities that your area has to offer. Find out those commonalities you can have. Yeah, and knows how cold it is. Exactly. We create a website, play where you work, and so it really builds on the different outdoor activities we have here to offer. So families really look for that. It used to be that physicians just wanted to go work. They didn't have hobbies. They work 90 hours a week. And more the residents are coming out. They're wanting to. It used to be maybe about 10 or 20% of residents coming out of their programs wanted to be employed by a hospital, or employed by a group, or employed by a big clinic. Now it's about 80%. So it's almost a complete change of they want to come out and have some stability. They want to be employed. They want to have the benefits. They want to work 40 hours a week. The Monday they want the banker's hours. And we have to adjust to that. It was hard. My CEO is of the older generation, and so he's like, well, what do you mean I want 40 hours a week? Because I do that by Wednesday, and these guys are wanting to only do that by, all week long, and never had to be on call, don't work weekends, don't be on, take any night call, anything like that. But you have to adjust to that because that's the type of people that are coming out of medical school now. They want that stability, they want that time to spend with their family, they want a quality of life. So you really got to be able to offer that to them. We advertise through social media. You go to other physicians that you currently employ and ask if they know anybody. And then just use any other current staff resources. These are things I talked about already you want to look for. Look for local ties. If they have family in the area or they have some type of a tie to the area, you really want to build on that. Find those people. Cultural fit. Church is always a big thing. Religion, if there's a predominant religion, bring them here, bring them there, and have them fit in the community. They want to be in a rural area, or have a rural experience. They already have an Idaho license. The family has some ties here. And then we go to the education part, and that's where we talked about, started looking for some of the higher caliber physicians of the Stanfords, the Mayos, the Cleveland Clinics, those types of areas, and bring that type of specialty here. A couple of we have a pain management doc that does his residency and actually his fellowship at Harvard. That's just something new that we haven't had in this region for a long time. So kind of cool to market that. Then you have to look at their different work experience, look at your employment model. We have a couple different models. You can employ them just as a regular employee on a salary, or you give them an opportunity to actually, they know what's called a worked RVU contract, which is production, so they get paid for what they do. And they a lot of them like that model because they want to build a real strong practice and work hard and they get compensated for it. Involve a lot of your people in your interview. The more people the physician meets when they're there, the more they feel like this is a solid team and they can ask more questions and get more information than they need. This kind of other stuff, just as far as go over all the different details about the community, the hospital. We really roll out the red carpet when they come. We go through a whole screening process like this is outlined, a phone interview, Then go through a group interview as far as on the phone and get some more questions. And then actually finally bring them out and if they've made it through those screening processes, then we bring them out and do an on-site interview. Saves a lot of money if you do those things beforehand versus just bringing out anybody that says, yeah, I'll come out and check you out. Because then they're really not there. They just, and you don't want to believe this or always think about it, but some of them just are out there looking to get a free vacation. So they know the hospital's going to pay them to come out and you just pretend like you're looking for a job and they get a free vacation out of the deal. So there's those that do that to you and you can't always identify them, but you try. There's just examples of some of the interview questions that we give. And as far as on-site, we leave gifts in the hotel room for them. We pick them up at the airport. We give them a car to drive throughout the whole time that they're there. Take them to dinner. Do a huge thing with all the current physicians at the hospital. Make sure they meet them. Do a lunch with them. Take them out. Do a real estate tour. Do a community tour. Really try to get a feel. You do all this in one day, so it's not like you have to spread this out over a week. You get all this done in one day, and you really get a feel for what the community is. They really got to be bought into the community, or else they're not going to come. You'll go through a different interview day. We meet with the CEO. They talk about all the different things that we offer here. Talk about compensation. Talk about our board. Go through lunch, dinner, tours of the facility and the community. And this is what I really like. We send them a gift after when they get home, after they get off the plane, and the next day a gift shows up at their house and they're thanking them to come. So little things like that a lot of people don't think to do. Do some contract negotiations and execute the agreement. And we have a team at the hospital that sets up everything once they've signed and get everything ready for them to show up on the first day and be able to see patients. So basically, again, just as you're looking at recruiting physicians in your communities or the facilities that you work in, just go through the same questions. You found good ways to make this work. This process works for us. I think it works for a lot of small towns who've had success in recruiting physicians in other small communities for other hospitals as well. So we think it works. But you have to find out what it is with your organization, standardize the process, and also be flexible. Because you may get a doctor that you really want, but there's certain things that they need that maybe you weren't willing to offer, but you know that that's going to generate a bunch more revenue for your hospital, so be flexible. Just physicians want to know that you're human. We want to know that physicians are human, and they really are. Build relationships with them, and come to common grounds and commonalities, and you'll be very successful with them. Any questions? Yes.
Just wanted to know, we don't have a ton of time, but just,
Sorry about that.
what are, no, you're good. We took the first 5 minutes, so we apologize for that. Just a couple main things that you do from day to day. Obviously, being an administrator, things are different day to day. But maybe like, are you over a specific job criteria versus an administrator? Like, do you handle the recruiting or?
So what I do is a couple of departments I oversee. I oversee physician recruitment, but I'm very heavily involved in as well. So I usually make the first call over the doc, try to help them, and then we have a whole team that takes care of it after that. I oversee all the physician offices. So we have 45 employed physicians, so that's 45 individual physician practices. So that's one of the departments that I oversee. I have a couple of managers that are in those departments that report to me. Health information management, which is all medical records, all the HIPAA compliant stuff, all the charting and then coding is all underneath that. So physician coding and hospital coding. And then I have all the construction renovation projects. So any of the any construction renovation you do in the facility or additional buildings we're building, we have I hired a general contractor that works for us in the hospital that reports up to me. And then any of the outreach clinics, the management contracts with other facilities, which are all handled there. So, but we're a pretty tight-knit, admin team as far as our group. There'll be times I'll be working on the surgery center. I'll be working on, with some of the other providers in the lab or the radiology department. So it's we've all been there. As far as a core team, I'm the newest in it, which is why I got a chief nursing officer. The newest, he's been there for 3 years, but other than that, everybody's been at least more than 8 years. And so we do work on a lot of projects. And area and aspect of the success that we've had in our recruitment. You know, that was just last year, 14 new positions. You know, we've already signed 3 more for this year that will be starting here in May, and continue to look. So, you know, always want to keep looking. Yes.
Now looking back and seeing people come into the field now, would you still suggest the MBA with emphasis in healthcare, or would you?
It worked for me, and if you look at, I guess, on our entire admin team, our CEO did the same thing. We got an MBA. Our CFO has an MBA. One of our directors of our ancillary services, he has an MBA, and so basically, in my experience, both when I worked in Ogden and with the team there, they were all MBAs and had some emphasis in healthcare, and then the team I'm working with now is as well. And there's nothing, but to say, there's nothing wrong with going into an MHA, because that really does set you up. I have friends that went to school with that went through that program, and they had their first job right out of school. I had to go find my own first job, because there's an MBA program, it's an emphasis in healthcare. And so that's the difference, I think. If you have some ties, if you know where you're going to go, if you have that opportunity, I mean, I just like the flexibility. In case you get in, and I was a farmer and rancher. I didn't know if I was going to like healthcare administration. And so figured if I was going to finish school, get it a little bit more broad, because then if I don't like that, you have a backup and go to something else. But looking back, I mean, either way would have been just fine, because I've definitely enjoyed it. That's the benefit.
I heard that they might cut the profit plus 2%. Have you heard anything
Oh,
about
for
that?
the critical access?
Mhm.
Yeah, they do
They didn't do that. So what if they do that, and so you have all these positions, you keep bringing more and more and more, how are you guys gonna stay above water if
So
they
we
cut that?
do, that's a good question. And so in small communities, small hospitals, we get paid a little bit differently from Medicare and Medicaid, because they want to make sure these small hospitals stay, open and vibrant, because many places, I don't know, some of your communities, it might be 30 miles, 40 miles, 50 miles to the nearest hospital, and it's a small hospital. And so that hospital is very much needed. We kind of live in a unique situation where we're kind of surrounded by them, but it's still, some people still have to travel quite a ways. And so the government pays you for, if you were to accept Medicare and Medicaid patients, and they basically pay you for your cost of doing business, plus usually a 1 or 2% profit. And that's been implemented ever since they started the critical access hospital program about probably 12 to 15 years ago. And so that's one reason we've been successful, because we do have, the more cost we put into the organization, the better reimbursement we get. But it is only based on the percentage of Medicare and Medicaid you see. And that's why some communities don't have a real high Medicare and Medicaid population. The critical access doesn't really help that much, because it's still meant to depend on the other payers and self-pay and all that kind of stuff. But what we do, as far as we want to kind of hedge that, we know at some point maybe it's going to change. And so we have a research license. So we went out and got a research license, so our physicians can participate in research programs. We started a med school, so we have 3rd and 4th year medical students from a medical school in Washington that we partnered with, that they come and move to Blackfoot, and they do all their 3rd and 4th year medical student rotation. So that helps on the other end. This summer we're starting our first internal medicine residency program, and so we'll have 4 residents that show up in July that will do their full residency program at our facility. And so you gotta look for other things that aren't directly related to reimbursement from the government, and try to build those. And that's the other thing with the joint ventures. If you do joint ventures, the physicians are really going to drive that volume to those joint ventures, and not have to depend on our payment from the government.
I know you guys have a lot of investments that make up for all the stuff, all the people that don't pay. So that's.
Yep. We're investing. We write off about $500,000 every month. So for people whoever can't pay, refuse to pay, or can't find it. So a lot of that's through the ER, a lot of it's through some emergency surgeries that they will pay. But $500,000 a month, you have to write off, and you'll never see again. So you have to find other ways, other avenues of generating revenue, because you got to understand we're right about the average of based on our volume across the country, what gets written off and you're never going to see and never collect. So That's a big chunk.
Yeah.
So you have to look for other things that can drive revenue to your organization. So, all right, well, thanks guys for having me, and
Well, let's give Jake a round of applause. No, we're really grateful. I got a lot out of it. We've talked about critical access in our classes, and I think it's really valuable to have a critical access perspective. So, is it okay if anybody wants to talk to you to meet out in the hall for a couple minutes?
no
Okay,
problem.
great. Thank you so much, Jake. Yeah, next week we're going to have, wow, I forgot his name, Blake Bedke. He's a graduate of BYU-I. He went into long-term care administration, and he's only been out a year, and he's already administrator of with assisted living concepts. So anybody that wants to perhaps go into long-term care, or who wants to get the perspective of it in terms of the hospital and long-term care dynamic, just come for him. He's coming all the way from Boise, so it'd be really nice to have some support. So please come to that. And then one other thing, we just designed our own new LinkedIn page. BYU Idaho Healthcare Administration. You'll either get invited or go find us, and we're planning on just kind of using that as another social media platform to list opportunities, reach out to other people, and list society speakers. So, yeah. Kyra, would you say our closing prayer?